really, really important in terms of EBCT scanning. 3 of the first 30 patients had negative calcium scores, but they all had soft plaque in the proximal left coronary arteries. And therefore, I believe that all those 3 patients would have been sent home on the basis of any of the other tests that we do and told that there wasn't anything to worry about. Whereas I believe exactly the opposite. And as Duncan says, the worry that I have about the NICE guidelines is that we have a recommendation for conventional angiography where from the time I first did an IVUS study in 1993, it's patently obvious that so-called normal coronary arteries aren't normal at all. And the presence of this soft plaque disease is maybe why so many of Adam's first group of patients came back again with coronary events, because they weren't identified with the tests that were being used at the time. And I think this is a really important point. I think that you can make a very good case for using low radiation CT scanning as a test for these patients to look for early disease. And I suspect that that was the question that Duncan was going to ask when it came to asking Adam about the appropriateness of angiography for the patients in the higher prognostic groups. I'm still worried that in that the mid-likelihood group, where you're talking about patients of 30 to 60% disease, you may well do non-invasive stress testing of varying types, and if it's normal, the patient can be sent away. With CT scanning, I believe you're not going to make the misdiagnoses that you might do otherwise, and I think it's a really important way forward for the future. As Duncan said, there's a huge amount of work to be done, but this was basically a study set up before the NICE guidelines come out. And I have to say that there was a certain amount of scepticism from my colleagues, and not just those who are running the invasive catheter labs at tertiary centres looking at prospective bookings for the future. So when the patients are referred, if you go to a conventional rapid access chest pain clinic, the costing is roughly about £200 for a consultation with a nurse specialist. Exercise testing we've already discussed. Costs vary between £220 and £485 in one centre. Stress echoes, again, much more expensive. MyoView scanning, again, much more expensive and vastly more radiation dose. If you look at this week's New England Journal of Medicine, I'm not sure whether it's actually come out, but in last week's email copy, there is yet another article on radiation hazard from CT scanning and from various tests used in diagnostic cardiology. Invasive angiogram we've discussed, but again the costs, we're talking about £1,300 to £1,500 based on tertiary centres and based on local district general hospitals. If they've got coronary disease, fine. If they've got normal coronary arteries, fine. But this way, seeing me is amazingly cheap, because I'm only paid £83 a patient for 6 patients in the afternoon. The resting ECG varies between about £15 to £25, and the CT scans are about £900. But there is a paper in the pipeline from Birmingham Heartlands using the Aquilian one, which they calculate that each scan can be costed at £140 a scan. And I would suggest that represents a remarkably economic way of assessing whether our patients have disease or not. I think there's a huge future ahead. We have to decide what the appropriate tests are, but certainly our preliminary studies have been very exciting, and indeed the value, as Duncan says, of having a patient in front of you with a moving picture of the coronary arteries, showing them what exactly is there, has a fantastic effect on doctor-patient relationships, and they really go away thrilled to bits because they know what's happening. And I really believe this is the way forward. Thank you very much.